This topic is appearance and motor behavior. Appearance. This is a part of a psychological assessment. How the client appears. We observe that immediately. It's a first impression. It's part of the nonverbal assessment we do. It provides evidence of the client's mental state and level of functioning. Appearance. Notice what you notice. Grooming and hygiene. Are they well kept? Do they have clean clothing that's appropriate for the weather? Are they clean shaven, or do they have groomed facial hair and then clean fingernails? Or do they work with machinery or manufacturing or farming? Or are they disheveled? They have inappropriate clothing or unkempt clothing with holes, or clothes that are mismatched. Are they dirty or stained? Or are they wearing layers of clothing and it's a warm, sunny day? Do they have dirty, uncombed hair or ungroomed facial hair? Do they have body odor? Is this the norm for the client, or at the last appointment they were well kept and now they're disheveled? Maybe their mental health is suffering. We also need to ask ourselves, does this client have access to bathroom facilities or laundry facilities? Age. Does the client appear their stated age, or younger or older? That client who says that they are 79 and they look 50. They exercise, they have access to healthy food, or maybe they say they are 50 and they look 79. Maybe they smoke or have other medical problems that have taken a toll on their body. Height and weight, which may tell us a little bit about their nutritional status. Posture. Are they upright and confident and relaxed, or are they rigid and they have pain or they're nervous? Are they slumped over because they're embarrassed and afraid, or have low self-esteem or depression? Eye contact. Is it excessive and they're staring and they're trying to be intimidating? Or is it appropriate? Or is it minimal or none? Are they afraid or embarrassed? Keep in mind cultural considerations. There are cultures in which eye contact is avoided to show respect, but also keep in mind that lack of eye contact can also indicate depression. We will also look for dilated or constricted pupils, because this may indicate substance use. Tattoos, scars, and body piercing. These may show us the client's personality and history, something they believe in, something they find enjoyable, or something that they are involved in. Self-inflicted injuries from cutting. And facial expression. This gives us a first impression. What is their mental state walking in? And it can change over the course of an appointment. Smiling when they walk in and they're greeting staff. Tearful if they've received difficult information like a troubling diagnosis. Angry. This could be in response to waiting in the waiting room too long or to a new diagnosis. Could they be surprised or showing fear? Motor behavior. Again, notice what you notice. How the client behaves or moves. Is it normal, goal-directed, deliberate and voluntary, purposeful, coordinated, and smooth? Alterations in motor behavior. These are inappropriate or illogical movements. Psychomotor agitation. That could be clenching your hands when you're angry, or fidgeting when you're nervous, paranoid, or have anxiety. It could be pacing, seen with clients who are nervous or angry. And then psychomotor retardation or slowing of movements, as seen with depression and dementia. The gait. How a client walks. Are they shuffling? You can see in this image what we may see with a client who has Parkinson's disease. And ataxia, that's movement without coordination. Catatonia. This is most commonly thought of as a rigid, immobile, or statue state, but it encompasses a wide range of symptoms, from rigidity like stiff arms or legs to extreme agitation. This can be an increase or decrease in a client's movement, how quickly or slowly they move, and the amount of movement. Echopraxia. This is involuntarily mimicking the movements of others. This can be mimicking movement they saw in a TV show or movie, or taking on the movement of those they are around in conversation. Stereotyped or motor stereotypes. These are repetitive movements with no logical reason. The movements are normally rhythmic, predictable, and seen in children, like thumb sucking, twirling the hair, teeth grinding. These may be linked to when a child is feeling excited, bored, or stressed. And gesturing or posturing. This is taking on unusual or illogical facial expressions, positions, or postures. Alterations in motor behavior, tremors, or tics. These are spastic or jerking movements. Tics are twitching of a muscle group, like a wink or grimace, seen with Tourette syndrome and tardive dyskinesia. And tremors. This is involuntary contractions of opposing muscle groups and will normally disappear when the client is sleeping. Extrapyramidal symptoms, EPS, like tardive dyskinesia. You can see an example in the image here. It's a side effect of neuroleptic antipsychotic medication in which involuntary movements occur around the face and mouth, like involuntary grimacing. Nursing interventions. Observe for gait abnormalities. Are they at risk for falling? Is this something new for the client? We may need to assist them with their activities of daily living. We want to provide a low stimulus environment with decreased noise and distraction, especially if they are agitated or have anxiety. We may need to provide medications for EPS and psychomotor agitation. We want to encourage the expression of negative feelings surrounding their involuntary movements. How are they feeling about it? Are they embarrassed or do they feel out of control? And we want to provide a safe environment for pacing by removing clutter so they can pace safely. Pacing may soothe a client who is anxious or agitated.